All right, so pretend it's 5 o'clock last night, and we're going to talk about hormone replacement. So I'm glad, actually, we caught you guys awake for this one. This has been a long time for me at trying to wrap my head around some of these things, and as Bethany said, we're still learning. So we're going to go through female. So Joel kind of walked us through what we're doing with our female patients, which ended with some HRT information. And then we need to know how in the world we're going to replace that and then monitor that. I wanted to just say a word about this chart. These sort of green, yellow, and red, I don't know it precisely. I almost want to type out what I want to say with that because I want to choose my words really carefully. But this is sort of the conventional HRT umbrella, right? So when you enter into HRT, this is a pretty good place to start. And if you want to venture outside of that, the person who helped me the most put this together is over 60 and on hormone replacement therapy, right? So, but when you want to go to the literature, you know, the risk for breast cancer and the risk for the benefits of estrogen, it starts to get a little murky in the literature, right? And there's more work to be done for us to better define this. But the message here is not necessarily to run away from hormones 10 years after menopause, but is to treat everybody like an individual, monitor what you're doing, do everything you can to push those risk factors, and to have a conversation with your patient, right? There are probably plenty of people out there who would say, okay, you just told me that by staying on this therapy, I'm moving my risk up from 1 in whatever to 1.4 in whatever, or whatever the numbers are. And if I go into that advanced risk quadrant, I have to give up my hormones, and I'm going to feel the way I know I feel without them. And they would happily sign off on that, especially with some of the benefits we know there are from HRT. So I just want to sort of give a little bit of a disclaimer to this. This is the conventional, not conventional as in progestins, but conventional as in how we handle HRT. And there really are more studies that need to be done. And I think when it comes to this topic, one of the things that can be maybe even more negative than using progestins is arrogance, to be honest with you. Because I've heard people get up on podiums and say things with the kind of certainty that makes you feel guilty for moving in another direction, and whatever they happen to be talking about. In some of those cases, I'm like, but they're not right on that particular point because the evidence has evolved. But it's still, this cake is not baked. So for a lot of people that say things with a lot of great certainty, if they had dinner with Bethany and she talked circles around them for an hour, they would come out of that conversation thinking a little bit differently and questioning the certainty with which they've just spoken. So we're all still learning. We're out ahead of the curve a little bit on this. That's a fun place to be, but know that's where you are and communicate with your patients accordingly, okay? Testing options. So we talked previously about why we're not including saliva in this discussion. I would encourage you to go back and watch that. The reason that we did this is this conversation gets a lot easier to handle when we extract that. So your testing options are serum testing, urine testing, which is where our Dutch test comes in, and then none. Now, none is not meant to be a cynical comment because why? Not every scenario can be monitored in a way that's clinically relevant. Right? Just because you get a number doesn't mean that number is telling you something meaningful depending on the scenario. Some HRT can be given safely without monitoring, and that's not true of all HRT. And serum and urine testing have scenarios in which they don't work well, respectively. So we have to break that down. Okay? So more specifically, serum testing is going to be, it's not even close, the most supported in the literature. In the pre-conference video on labs, if you watch that, you'll get a nerdy little rundown from me on why we need to use LCMS, particularly in women, because once you get postmenopausal, the LCMS is going to give you a good, accurate number. You don't want to use an immunoassay. And for testosterone in men, you can kind of use whichever you like, and they should work. But when you get down into that female range, you want to use an LCMS assay. Urine is nice because you get less within-day variability, right? So patches are steady, and you can kind of get away with serum or urine. When you get into creams and gels that go up and down throughout the day, I think that's a nice place to use urine in particular. And obviously, we get to look at the metabolites for that. So these are the three things that as you work your way through why something wouldn't work for, why can't I use serum for that? Why can't I use urine for this? These are the three things that catch us up. So pharmacokinetics. So I mentioned creams and gels, right? If it goes up and down really fast, you're going to have a problem with that. I'll give you an example to run down all three of these so we can kind of digest those mentally. This is a reference that I would like you to have. We have it out in front. This is kind of 12 years of my just digging through stuff and trying to figure out where can we do this or that. And even this is evolving. Like I just learned over the last year probably, shamefully, that you can't use a urine test to monitor vaginal progesterone. Vaginal estrogen and testosterone, yes. Vaginal progesterone, no. And we'll go through, so we're going to go through some of the specifics of this. But I would encourage you to have that as a reference just so this is basically the short version of this lecture. So listen to this lecture. This will kind of lead you back to why some of these conclusions are what they are. So sublingual hormones is something you can use in particular situations. I don't really like it for things like estrogen because you swallow way too much of it. But it's a really nice highlight of these three problems. So you can't measure sublingual hormones in serum well. Why? Because of pharmacokinetics. Okay? Here is transdermal testosterone. Okay? Now, is there a difference between the three doses? Yes. If you send someone in for a blood test and all the action is happening within an hour, and even at 60 minutes, you can hardly tell the difference between the three doses, right? So am I saying don't use sublingual testosterone? I'm a chemist. I don't know. It's not really my call. It wouldn't be my first choice. But if you do use it, you cannot lean on the labs to give you meaningful feedback on whether you got the dose right. That's the point I'm making. Okay? The pharmacokinetics, anytime the up and down is too fast, serum is really tricky. Okay? Now, why not, well, let me say this. Urine test is perfect for this, right? Because you can go to the bathroom here, take your supplement, and go to the bathroom here, and you catch the whole thing, right? So we win, right? So, except it doesn't work because you swallow too much of it, right? So here's a woman, real life example, of a woman taking sublingual hormones, right? So she's high for estradiol, she's high for progesterone, she's high for testosterone. So I said, all right, you know what, let's test you again, get off of it for a couple days. Okay, so here are my values off of it for, I don't know why the estrogen came down that low. That's really unusual that it drops off that fast. Usually testosterone drops off faster, but why doesn't this work? So let me show you why. So if I take something orally, so my HRT goes in my mouth, the stomach here is a stomach, but it represents the gut, okay? So what do I have? I've got a whole bunch of estrogen in my stomach. Now, some of it, what I'm showing you is why urine testing isn't going to work here, okay? So let's say sublingually I got 50% in, but I swallowed the other 50%. What happens to that 50%? Some of it's going to get in. It's going to hop on a binding protein, and it's going to end up in your serum. And then some of it is going to hit the liver. It's going to get conjugated. It's going to end up in your urine as a conjugate. And some of it's going to slide into your saliva. If you were wanting to do a lab test, that's what you would want, right? But what happens to most of this? It gets turned into metabolites. So I've got estrogen and estrogen metabolites. Within the gut, I create a conjugate. That's never been in circulation as a free hormone. And then where does it go? Now it's going to go into circulation, and it's going to flood what? The urine, right? So those don't count. Does that make sense? So you're getting a big, stupid number is the way that it generally works. If you want the most obvious example of this, take oral melatonin and then do a Dutch test, and instead of 10 to 80, you'll get 3,462, and then you'll call us and say, oh my gosh, I got like a serotonin-making tumor or whatever. No, it's just what happens when you take oral hormones. So a Dutch test is a great way to get a baseline for melatonin. It's entirely and completely useless once you're on therapy that's oral, okay? The only time it works for oral is with progesterone, and that's a little complicated, and we'll explain that, okay? So sublingual hormone's a no-go. So what does that mean? It means your high results here don't mean you're taking too much hormone, and the low results or normal results don't mean you got it right. It's a bad tool for that situation. It also means that urine testing is not going to work for oral estrogens, or you're not going to take these, but it doesn't work for that, okay? All right, so that's that. Oh, lastly, contamination. So we're not talking about saliva, but it just makes a good example. That's a football field, and that's the sun. Okay, the amount of hormones that are in your saliva naturally, if that represents a football field, the amount of hormones you take sublingually represents from one end of the football field to the sun. Like, it's literally that big of a difference, which means if you dump all of that in your mouth, it might work clinically, but if you go fishing for a meaningful number from that body fluid, like, it's a complete waste of time, right? Which isn't the fault of saliva. It's not the fault of saliva labs. It's just a bad match. So it just so happens that sublingual hormones don't have a good match, right? If I had a hair assay for you, like, that might work well, but there's no commercially available assay that helps you with sublingual hormones, okay? So, scenarios without good testing options. Not going to do the transdermal progesterone story because that's a long story, but I don't think any labs give you meaningful feedback on transdermal progesterone or sublingual hormones. You can use these clinically. You can't lean on the labs to say, hey, I got the dose just right, okay? That's the take-home message. Okay, just to summarize this before we kind of get into it, these are scenarios where I would say you want to use only serum. Vaginal progesterone. The urine, I'm going to show you why, is an underestimation. The serum represents, I think, systemic progesterone well, but what's one of the benefits of vaginal progesterone? Is that you get uterine first pass, right? The serum doesn't represent that. There's no body fluid that tells you what the uterus is doing when we use vaginal progesterone. We just know a truckload of it gets in there, right? So serum works, but kind of, sort of. And then with oral estrogen, you don't want to use urine and you don't use oral estrogen, but if one of your patients comes on it, a serum number is more meaningful than a urine number. Scenarios where only Dutch works against, we'll talk about this later, but I think oral progesterone, it gives you meaningful feedback, whereas a serum test does not, and I'll show you why. Okay, so let's talk about estrogen replacement therapy monitoring. Okay, I'm just going to get this out of the way. If you're on oral, you don't want to use it for reasons that people talk about lots, but if you do, serum's the way to go. So these therapies have good testing solutions. Okay, patches, gels, creams, vaginal application, and pellets. Not going to talk much about pellets, and vaginal creams are a little bit different, so we'll talk about them at the end. So this is where a lot of work is done, right? Patches, gels, and creams, and all of these can be tested with the same general considerations, okay? Now, lesson number one, which, as I mentioned yesterday, Bethany was the first one to really open my eyes to this, is you do not need to get to the middle of these are our ranges, right? You don't need to push someone from here to succeed clinically. And we need to get that straight if we're going to maximize benefit and minimize risk, okay? So this is probably a little aggressive. I need to kind of redo this. This is probably a little too high. But getting outside the postmenopausal range and into maybe the bottom third of the premenopausal range seems to be kind of the sweet spot where we know we're getting benefit clinically and we're hoping to keep the risk of having too much estrogen under control. So if we move that to serum, so outside the postmenopausal range up to the bottom third, about 20 to 60 is a pretty good range to find yourself in when you're on transdermal estrogen and you're monitoring in serum. Now, why? Why do we like that range? And that's from really reviewing what the studies say of watching when do hot flashes subside relative to placebo, that's important, and when does the bone mineral density increase, okay? So here's a really good takeaway, I think, and goes to your question we were talking about beforehand of like, hey, I use a cream of a particular dose. So I would imagine this is not something where we have enough information to state with tons of certainty. But from all the studies I've looked at, here's an interesting fact. 0.25 of Divigel, these are all like your pharmaceutical transdermal products, not all of them, but a lot of them. 0.75 estrogel, 1.5 Evamist, and 3 milligrams of estrozorb. They all have something in common. When you look at the studies using them, that's the dose at which they barely work. Meaning, if I do a hot flash study for my FDA whatever, I test hot flashes relative to placebo at 4 weeks. Does it work or not? Those doses mostly don't. Then I test again at 5 weeks and 8 weeks, and they start to work. If I use a higher dose, like 6 milligrams of estrozorb, no thank you, now that dose works at 4 weeks and at 8 weeks. So does that make sense? Like that's the dose at which we're breaking its back in terms of it's finally working clinically and giving us the type of impact that we would want to see. And at those doses, that's where the serum results seem to be creeping up and out of the postmenopausal range. That's where I get that conclusion that it makes sense to push people up and outside the postmenopausal range. So let me show you this from a study. Here's a study where they used 0.75 of estrogel, and they got serum levels of 32 to 34. And you say, well, that's a lot of hormone to get your serum levels up that high. Maybe serum's not the best way to test it. But when you look at Yang's study from 2007, same exact product, and of course, these people are really irritating. One of them reports serum, one of them reports bone mineral density, and neither of them report both. So that's the challenge, that why I've spent way too much time digging through the literature. But same product, same dose, no bone mineral density improvement at 6 months, but they did it 12 months, right? So 0.75 dose and placebo, no difference at 6, difference at 12. When you look at the higher dose, it worked at 6 months and 12 months. So that's where you're getting those serum levels that are up and out of the postmenopausal range. Now, when you look at a patch, even the low dose of 0.025, right, is working at 6 months and 12 months. So patches work really well when it comes to the clinical impact. So here's your 3 milligram dose. Now you say, how can they get away with so much less estrogen in a patch? Well, first off, the patches are nice and flat, and the creams and gels go up and down a little bit. So those serum numbers, 30 here is not exactly the same as 30 here, but it gives you a good ballpark. Here's the only data I can find where they're using cream. This is the biggest frustration for me in the data. I mentioned this yesterday, is there's no data on serum and creams. This is the only paper I've found, actually Joel found this one, thank you Joel, that shows that, hey, at 0.6 of estradiol, the values are starting to come up. Well, that's nice, but they're back down here, and this is why I'd rather use a urine test for this. But you just can't find enough data. And this is something I would like to support, is getting more data where we've got serum and urine on different doses of different products, because there just isn't enough data out there. But this is something interesting to know. I mentioned the patch dose is so much lower. You know how much estrogen is in that patch? 4 milligrams. It's not a 0.05 patch, right? That's an effective dose. So that's part of the confusion, is when I talk about a cream and a gel, I tell you how much estrogen's in that thing. When I talk about a patch, have you ever heard that you're putting on a 4 milligram patch? No, right? They look at the serum values, I think is how they figure that out, or they weigh the patch, I don't know. But they figure out precisely how much is getting into you, and that's how they name it. So you could probably name that gel a 0.06 milligram gel or whatever, and that would be more in line. They just don't do that, right? So it's a little bit confusing. So just know that patch dose is an effective dose, not actual, okay? Now, when you look at our data, and I think this is really nice data. This is based on 1,300 people. When they use, the reason they end up at these doses is because they work, right? So the low doses for these patches and creams, or creams and gels, barely work. And look what they do. They push postmenopausal women outside that postmenopausal range and out of it just a little bit, same as the low-dose patch. And if you keep going, so then the question is, where do you want to find yourself? And that's where you got to treat everyone like an individual, right? What are our goals? What are we trying to do? But know that when we do this test with those products, we get the type of response that we want. This was not something I was expecting, honestly, when we started the lab. We started reviewing data, all the studies, and we said, hey, what do you know? Like, this is actually a really good monitoring tool for this, which is good. Now, in serum, you can see the same type of pattern for gels and patches, out of the postmenopausal range and up here, right? There's just no data on creams. Now, to one of my earlier points, you might ask yourself, why did the patches have higher baseline values than the gels? Doesn't make a lot of sense, right? Probably, and of course they don't tell you in the study, that's probably an LCMS assay, that's probably an amino assay. So these are different assays, which is why the orange line is probably lifted a little bit above that blue line, but that's why we want LCMS, because I want to know what that value is, and that's a better way to do that, okay? So you're getting a really similar pattern in the urine and the serum, at least with the gels and the patches, and when we move to creams, it still overlays with that data with the urine testing. So where does that leave me? For serum testing, these would be my conclusions. Patches, even the lowest dose improves bone mineral density. That goes clear down to, what is it, 0.014 or whatever. They've shown bone mineral density. Helps with hot flashes. 0.025 is a good place to start. It'll push your levels above serum at 20. The gels, doses that push the serum levels to 30 or 60 is a pretty good way to go, and it depends on how much you're using, right? And it depends on which product, right? It's really product specific. And I personally like to lean towards a product that actually works. If I can use 0.25 and get there, I'd rather not slather estrogen all over the place if I don't have to. But then you know, maybe you don't like an alcoholic gel, so that depends too. For the creams, very little data. I've mentioned it over and over again, so I'll stop saying that. But limited data suggests maybe you start at 0.5, something like that. But then you need to monitor levels, right? So these are our targets for me, is outside the postmenopausal range, at the top of that, up and into a little bit of the premenopausal range, and then your serum target. Okay, so well, where within that should I shoot? And this is just sort of my sort of general musing on this, is what do I care more about for a particular patient? Maybe you care about both, but if I've got a woman whose mom has osteoporosis and I'm really worried about bone mineral density, obviously there are other things you can do to help bone, but maybe I'm being a little bit more aggressive. Whereas when a woman's got, you know, a sister with breast cancer and those types of things, then you definitely don't want to push very high. So how you shoot within that target depends on an individual basis. So if breast cancer is more of a concern, maybe you shoot on the lower side. And just as a disclaimer, when I say concern for breast cancer, obviously there are patients that are in certain categories where we might need to stay away from estrogen replacement therapy entirely. But if your concern is more towards breast cancer, you might want to stay on the lower side of that. And again, those are things that have not been that well studied, right? When you look at the studies and they say, hey, we've got to use 200 milligrams of oral progesterone, that's what the data says. It's true, but all those studies use more estrogen than you might want to use, right? So no one's gone back through and done those studies again with an ultra low dose estrogen. Some of those things are not known, and more research is needed. So when we want to talk about breast cancer risk, this is something that we've kind of focused on with the Dutch test, is to try to add as many little variables in there as we can, right? Because we know that estrogen metabolites matter. We know that phase 1, phase 2, low progesterone, low melatonin, right? The actual marker that we measure, waking 6-hydroxymelatonin sulfate, is lower in women who get breast cancer. Flat cortisol curves, 8-hydroxydeoxyguanosine, glutathione deficiency, all those things matter. Let's talk more specifically about this combination though. Poor phase 1, poor methylation, and glutathione, and how it impacts the genetics. So this is kind of interesting study. So in this study, they were looking at genetic. They're looking at these SNPs, right? And they said none of them correlate to breast cancer. Too bad. But when you look at them in combination, and you look at women who have all 3 of these, the breast cancer risks are way higher. So what are we looking at here? And this is, we're happy to have Dr. Rogan with us here today. A lot of her work is we're going to look at some of that now in terms of the danger of turning estrogen into these DNA addicts. So that's 4-hydroxyestrogen right there, and it has broken a piece of your DNA off, right? That's adenine, and that's guanine, and the 4-hydroxyestrogens are the bad guys that do that. So this is a simplification of what she puts in her papers will make your head spin. This is the simple version. I'll show you her version here in a second, okay? So estrogen goes to 4-hydroxyestrogen. We'd like to prevent that if we can. And if we make it, we can methylate it. If we don't methylate it, it makes a quinone, right? Quinone we can get rid of with glutathione. There's also the quinone reductase, so that's where resveratrol can be helpful, and sulforaphane, right? And if you don't get any of these escape hatches, then that's where we're looking at potentially increased risk for cancer, okay? And this is some of her work where we're looking at high-risk people and people with breast cancer making more adducts than those who are healthy controls. Okay, catechol estrogens, the damaged DNA, they're the bad guys. There are many steps along the way, right, that encourage or discourage the formation of those, and nutrients and genetics play a role in those. So we'll memorize this quickly, and then we'll move along. This is the same story. Estrogen goes to a DNA adduct, right? And everything in red is not so good, and everything green pushes you back in a better direction. It's actually a really interesting thing to look at. You know, look at resveratrol helping us there, and glutathione helping us here. Like, it's actually really interesting to kind of go through this a little bit in detail. When we look at this study, let's show specifically where this is. Okay, 3 genes, right? So CYP1B1 does what? Gives you 3 times more 4-hydroxy, right? And then that woman also has COMT, as do I. So my methylation of estrogens, always in the tank, because 3 times less activity when you're homozygous for that. In addition to that, we've got SOD problem here, so our detox. So we haven't even included glutathione in the conversation, right? So imagine these women also have glutathione problems, even worse. But if you add these 3 things up, what do you get? A lot more DNA adducts, right? DNA damage, and there's your carcinogenic potential. So estrogen's path to destruction here, and we can intervene, right? Your genetics might stack you against that, but either way, it's our job, if someone's on estrogen or having an issue with this, to try to help them do what they can to push things in the right direction. One option is, and this is another of Ellie's papers, NAC, right? So lots of adducts, no NAC. Add lots of NAC, fewer adducts, right? Why? Because it helps push this back to here, and it helps get rid of it here, right? So it helps actually like 3 different steps on that process of increasing glutathione and conjugation and all of that, and that helps us to prevent more DNA adducts. All right, so those are the things on our test that can help you just shove that risk profile back. And when you look at all the HRT studies, no one's doing this stuff, right? So those studies don't represent somebody in this model doing this, and I would love to invest and get involved in studies where they're doing HRT and monitoring these things to see what the outcomes would actually be. So here's our estrogen summary. Okay, transdermal's the most studied, might be your best option. Optimize levels based on symptoms and risk. You're going to want to optimize phase 1, look at methylation, support it if it's poor. I will say, Dr. Trindade was telling me of her success in actually moving those meters from low to high. I've seen a lot of people do, let's just call it methylation support, and it doesn't move much. And so I'm not sure entirely with what you're doing if there's necessarily wisdom in just giving more and more and more until it moves. It may mean that you need a different approach to supporting methylation. I've found it to be rather stubborn in some patients. So I don't necessarily say whatever you're doing for methylation, just do it until that thing flips. But it can tell you for sure when you need to support methylation for someone like myself that has poor methylation. Balance with progesterone, of course. Okay, so progesterone replacement. If your estrogen's higher than the postmenopausal range, we're going to want to support with adequate progesterone, right? So oral progesterone and serum. So this is a little bit frustrating. What's our priority? Our priority is the endometrium, right? And so in wanting to protect the endometrium, we want to know what circulating progesterone levels are. That's what we want to know, which we can learn by measuring them in serum, duh, or we can measure them indirectly in urine. Well, guess what? Neither of these work. Not for progesterone, but when you're on oral progesterone. Neither of these is going to tell you what your circulating progesterone is. Serum values are not accurate. They're not useful when you're using oral, and it can actually be really misleading. So let me show you the data. Okay, here's a study where we use your classic progesterone assay. You take progesterone at bedtime. This is 100 milligrams. The value goes up and back down. When do you measure? If you take it at bedtime, how many hours? 10, 8, right? You've already missed it. But what you've missed isn't even real. This is an immunoassay. This is a mass spec assay. If you test at 2 hours, progesterone's back at baseline. But when you do a standard progesterone assay, what have you just created? Gobs of things that look like what? Progesterone, right? First pass, you get all these metabolites. They lift up that number. So that 12 is more or less a 0, right? So you don't want to chase that number. That's my point. If you give 500 milligrams, the tail of this will be big enough that you could chase that number. Don't do it. It doesn't make sense, okay? And then if they switch to a mass spec assay, you're never going to see that, right? So I heard a guy lecturing once as saying, hey, this is really easy. You just give progesterone until you get a 20 in serum, and he's like being really arrogant about it. And I'm thinking, like, you have no idea what the heck you're talking about. And then at break, I heard him saying, something's wrong with my pharmacist because I'm not getting those big numbers anymore. And I said, well, they probably switched to a mass spec assay. So you were chasing this tail, and you might feel good about that 20, but it means nothing relative to your treatment, right, except that you gave treatment. And with the mass spec assay, you're never going to get a luteal number, right? So if you chase that number, you're just going to overdose. So I wouldn't, progesterone's great in serum, just not when it's oral, okay? Now, the urine, all we get are the metabolites, right? Which doesn't tell you the circulating progesterone levels in this situation. We get very high levels of metabolites. Why do we care? Well, because you're essentially giving a pro-hormone here, right? Like, why does progesterone help you sleep? Progesterone doesn't help you sleep. It's what? Allopregnanolone, right? So a lot of the clinical impact you get from oral progesterone is based on the metabolites. So that's allopregnanolone oral. That's allopregnanolone vaginal, right? So you put it into the gut. Yes, you destroy a lot of the progesterone, but you get stuff in this case that's actually useful, right? You take oral estrogen, you get all kinds of metabolites, like you don't actually want them. In this case, you're actually being strategic often in trying to create these metabolites, okay? So much of the clinical effect is from the metabolites. So observing those patterns is helpful. So this is progesterone, okay? It goes down this alpha pathway, and we get allopregnane dialglucuronide. That's what we measure. It also goes down the beta pathway, which is less active, and we get beta-pregnane dialglucuronide. So we measure both of those, right? So it represents both major pathways. When you're not on therapy, these levels have been shown and published to correlate really well with serum progesterone. So they're a surrogate. As soon as you take oral progesterone, it's a completely different world, right? We're trying to do something totally different. Now we're trying to see your metabolism pattern. So look at these two women, okay? The alpha pathway here, that's the allopregnanolone pathway, is low, and here it's really high. So this woman, so one of the women, so this is like a sequential metabolism. I forget which way it is. I think it is the gut bacteria push it beta, then the intestinal mucosa push it alpha, and then it gets to the liver and it goes both ways, right? So depending on what's going on in your gut, you get really different metabolism, right? So this woman pushes down the less active pathway, this woman down the more active pathway. So if neither of them are sleeping, to me, and this is not something you can well establish with the literature, but it makes sense to say, look, you don't make as much of the sleepy hormone as all of your friends who are taking oral progesterone, so maybe I'll give you a little bit more, right? Whereas this woman, if she's already pushing heavily down that alpha pathway, I'm going to go bark up a different tree, right? I'm going to look at melatonin, I'm going to look at cortisol, right? So this is typically the one that urine labs measure. So these women look the same, right? But they're really, really different, right? So that's why we like to look at both pathways. We want to look at the alpha pathway as well as the beta, okay? So here's somebody who's low. So do I care that they're low in the range? I don't care at all. This is not that sophisticated. All we're asking is which way do you shove it, right? The reason she's low is one of two reasons. One, she took a low dose, okay. Or she didn't take it the night of the test. You might be shocked to find that not all of our patients follow our instructions. So the worst offenders are in this room because we never have a higher percentage of people who screw up collections than doctors. You're busy, I get it. But the instructions will tell you don't take oral estrogen the day of the test. Oh, don't take my oral hormones, got it, right? It'll tell you take your oral progesterone the night of the test so we can see it. If they skip that, you're going to still get residual metabolism. The point is, you can still see what's she doing here? She's shoving slightly alpha over beta. That's a really mild preference, but you can still evaluate. The fact that she's low in the range is completely irrelevant in this case, in terms of her metabolism. We can still evaluate relative metabolism. Now, these women are not sleeping well, okay? Lots of alpha metabolites. Let's just give them more oral progesterone. Why would we not want to do that? Because you're making these metabolites, you're also making these little tiny pregnine metabolites that I really wish we could measure, but they're too small, okay? John Weeb's work, which has never, this is sort of 216-ish, okay? His work's never, the ball's never been picked up here. He did a bunch of work in vitro. It looked really interesting, and no one seemed to care. But alpha metabolites, breast cancer cells in vitro, pregnine metabolites, okay? The alpha metabolites might be proliferative. So if you're pushing heavy alpha, I just have a hesitation of saying dump some more oral progesterone to that woman, okay? So just something to be aware of. Again, this is not, I wish someone would pick this ball up and run with it, but they haven't, okay? So 200 milligrams is the proven dose, but that's on doses of estrogen that might be significantly higher than what you're doing. So that's something to know, is that's what you can prove from the literature, but just know that's where it's coming from. Serum testing is not helpful, right? Urine metabolites are helpful, but not necessarily to the central issue of endometrial protection. Okay, so know that. And this is one of those situations where Joel mentioned you don't have to measure oral progesterone. That's true, right? You can get away without measuring it because we know that it works, but the lab values don't get to the central issue, okay? Okay, so pharmacokinetics is the problem with serum testing for that. Sublingual oral progesterone, that's going to be a problem. Be careful with creams and gels with serum, meaning if you get a low serum number, did you hit a trough? And if you get a high number, did you hit a peak? You got to keep that in mind, right? An estrogen, we almost hit 60, and we almost hit 20. The difference between 20 and 60 is pretty significant, right? So it's going to go up and down. Just know that. And that's where I think, urine test might be a better option. With a patch, it's nice and flat, so the serum number is pretty rock solid. With the cream, same thing, right? This might be the reason why serum doesn't go up. I don't know. But if you give these people hormone and you test out here, you've missed all the action, right? So, and some of them don't absorb very well, so it's a little bit confusing, and serum might not be the best tool to help you figure out if you're giving enough hormone. Okay, contamination. This is not a non-issue. If you have a woman put topical progesterone on her forearms, and she puts it right there, and she goes to get a blood draw, like, I've seen it. You can get a really high number, so be careful of that. The more relevant issue for me, since I don't do any serum testing, is vaginal and hormone and urine, right? So if you take a vaginal hormone, it doesn't make sense to use urine, right? Unless you work with a lab that spent a whole extra month figuring out how to remove the contamination, okay, which we did. So here's your hormone. What happens? It doesn't get into urine. Why? It's not water soluble enough, okay? It hits the liver, it gets conjugated, and then it goes back into circulation, and that's what we find. So should we find any sex hormone that's free in your urine? No, right? It's all conjugated, okay? So then, here is urine depicted without contamination. Let's just say this is a woman who used vaginal estrogen, and you got a bunch of estrogen that got in your urine having not been in circulation. You don't want that number, right? This doesn't count. So how do we do a test to give us this and not this? Trade secrets, here we go. So the standard urine method is you break the conjugates. Anyone know how we break the conjugates? Snail guts, literally. So snails have a lot of beta-glucuronidase, and so we use it in the lab to break those bonds. Now it's free hormone, which I can measure more easily, and it goes to the lab test with your contamination. So what do? We say we don't want that, so every single test we do, first we dump the free hormone to waste, then we call on our friends the snails, and then we do our lab test, right? So we're able to get, even with a cream, right? If you get your testosterone cream on the sample, then we're going to remove that contamination that we don't even know is there, right? So that's been an important thing for us to be able to do that. So vaginal hormones are unique, right? Because you can use a low dose for vaginal hormone replacement therapy, meaning helping vaginal atrophy. What do you want to do there? That number, for me, is the top of my postmenopausal range. If you keep it below that, you can pretty well assume that it's all localized effect, right? If that's what you're trying to do, that's what you want. Okay, here's a woman on vaginal hormones, again, postmenopausal range. She's in the postmenopausal range. Her symptoms in that general region are better. You have succeeded. If you want systemic hormones, you have failed, right? How about this woman? Little higher dose, labial application, and we're bumping them out of the postmenopausal range, being conservative. It's biased, so look at the estriol go up a little bit higher, right? And then we can look at metabolism patterns, right? So if that's what you're trying to do, that's what you get, right? So higher dose for systemic effects, which means you probably want to treat it like transdermal in terms of your target values. This is something I want to be really careful about. We can sometimes casually throw around words. I put hormones on, it's topical. Where is it? Well, I want to be really careful with my language. Transdermal and transvaginal are not the same at all, right? In terms of what's going on in terms of uptake of hormone. Okay, serum results are way higher when you put it on a mucosal membrane, right? This is a barrier. My skin's not meant to just let everything through. Mucosal membranes are different, okay? So, this might be a little bit irresponsible. This is someone who's just using gobs of hormone that way, and you want to be really careful that if that's in the top third of the vagina, where's it going? Uterine first pass, right? The lab doesn't even speak for that, so it's going to have more than that, okay? So again, don't confuse vaginal with transdermal when we're talking about them. That tissue is much more vascular. So check this out. If I use 0.5 milligram of transdermal estradiol, I go from 10 to about, 30? Not 50, right? If I use a 0.5 milligram micronized estradiol, this is from a study, they got over 1,000 in serum, okay? So it's way more absorbed when you use it vaginally, okay? The other thing that's weird is when I make estradiol, I get a proportional amount of estrone and a proportional amount of the metabolites unless I have screwed up metabolism, right? For whatever reason, it doesn't. You get way less estrone. Now, I don't know if that's good or bad. It just is. So we need to know that, okay? So here goes the estradiol. Boom, way up there. Now, it's pretty flat. Testosterone's not flat. Estrogen's flat. So you can use serum for this, okay? Or our urine assay. Look at the estrone. Remember, estrone starts higher than estradiol. And when you take it vaginally, the estradiol's way up here, okay? This same phenomenon happens in progesterone. What am I doing with progesterone? I'm measuring a downstream metabolite. You get less of them proportionally. Don't use my test, the Dutch test, any urine test to monitor vaginal progesterone. It doesn't work. You'll use a higher dose than you think. Here's another study that just shows the same thing. Estradiol's up here. It's nice and flat in serum, and it's huge, right? This is a pattern we see often that I'm still trying to understand entirely, but it goes to that point. See the estradiol here? I used to think this was some weird phenomenon that couldn't possibly be right until I found that it's the same pattern in serum. You get big numbers of the hormone you're taking, this is biased, but you don't get a lot of the downstream metabolites. That's not a patient who has faulty phase 1. It's a pattern we see commonly with vaginal hormones. Okay, lots of the parent hormone and less of the metabolites. Okay, this is the big issue. Okay, this is oral estradiol. This is vaginal estradiol. This is the ratio of estradiol in the endometrium to the serum. Okay, so with oral, this matches physiology, I think, about. And when you take it vaginally, you get a lot more. Now, it's not that simple of a message, though, because there's a difference between labial and vaginal, right? And what's annoying about these studies is they often don't tell you where they actually put it. But in this study, I presume it's actually in the top third of the vagina, and you get gobs of estrogen in the endometrium, and that's something to be aware of. The top third of the vagina, you get uterine first pass, or in the top, not in the bottom, right? So be aware of this route of administration. It hasn't been that well studied. That's the thing that's frustrating that we need more research on, right? Let's say I'm using it labially, maybe not me, someone you know. Okay, if it's used that way in 2 women, and one woman says, I hate what gravity does to this, so I take it at bedtime. And the second woman says, it's fine, right? Maybe it's a difference in how much actual cream you're using or whatever. Now, laying down for 8 or 10 hours and standing up, is that going to be the same in terms of risk of it getting to the endometrium? I have no idea, right? What I'm saying is I haven't found studies where they've really figured this out. So if you want to use vaginal hormones, I think it has great potential. You want to keep your doses low. Do not think about transdermal doses. We got to look at the studies when we're looking at that. We actually have a guide out there for dosages that just show common doses. But be careful. Just know you don't have gobs of literature to fall back on, okay? And it's another area where I would really love to promote research and be involved in research. Because I think there's great potential in that, and I think some of the providers that are doing it intelligently seem to be getting great results and don't seem to be increasing risk. The thing is, you just don't know, and you may need to do some endometrial observations if you're going to go that route to be certain. particularly if it's not labial but truly vaginal. Okay, vaginal testosterone, just real quickly. This is an example of the whole pharmacokinetic thing. Now, this says vaginal testosterone. It's actually vaginal testosterone something something. Like, I don't think it's cypionate, but it's something like that, which I think is weird, but it makes a point. This woman, same product, peaks at 8 hours. This woman peaks at what, 3 hours? And she's at baseline at 8 hours, right? So the point is this. If I put a woman on vaginal testosterone and say, hey, go get a blood test, right? You don't really know where the peak and the trough is. Now, estrogen's going to be nice and steady, according to any of the studies I've seen. Testosterone seems to move faster, so that's where I like urine, because we collect over that whole time, right? So I think it's a better way to get a handle on vaginal testosterone, okay? So I mentioned that when you take it vaginally, you get less phase 1 metabolism. So this woman is on testosterone. She's got an 18. The range ends at 14. What does that mean? I don't know. I don't know what this means. Is this too much? Well, she doesn't have any symptoms, so maybe not. This is the most potent androgen. She's not making very much of it, right? So she's also pushing beta more than alpha, which is the less androgenic pathway. So all that to say, there are not hard and fast rules when you do things like this, because you're getting outside of convention, right? Normally, 18 is too much testosterone, but it comes along with a 7 for DHT and a 34 here and an 80 here, right? Which is different here. So what does that mean? I don't know. What it means is you have a little more testosterone than the average premenopausal woman, and you have lower levels of metabolites. Do with that what you will, but I think it's actually a pretty nice way to take hormones, but you have to work with it a little bit to figure out what your expectations are from your labs. Vaginal progesterone, I already mentioned this. Gobs if it gets in the uterus. There's no lab that speaks for that. Serum's a better option for systemic progesterone. You want to know what's in the breast? Do a serum test. You want to know what's in the uterus? Look at the literature. And there's not gobs of literature. Now, Joel mentioned vaginal DHEA. Now, this is one where you can actually be really smart about it. You can fly under the umbrella of FDA approval with 6.5 milligrams and say, 1, it helps vaginal issues. 2, you don't get, so they say, systemic exposure. Okay? So here is that one. Is the DHEA went up a little bit. This is the preliminary study. So that looks like systemic exposure to me. I don't know. But guess what? You don't get any testosterone from it. Okay? So if that's your goal, go for it. What if your goal is to increase testosterone levels? Use a little more of it, right? When you use twice the dose, right, you get systemic testosterone that's nice and flat, right? So you can use that strategically if you're trying to give testosterone. So that's something to think about. The point for me is that this is a monitoring lecture, right? If you give vaginal DHEA, the urine test or the serum test should give you a pretty good angle on how much downstream stuff you're making from it. Then you figure out what you're trying to do. If you're trying to avoid it, then keep it at baseline with your dose low. If you're saying, I'm going to be smart about this and outthink the system, and I'm going to give more, and by way of doing that, give a little extra testosterone to my testosterone deficient patient, go for it. Oral DHEA, just as an aside, when you want DHEA or DHEAS and it is oral, actually, I would say across the board, I think DHEAS is a little weird in urine. It correlates to serum worse than anything else we seem to measure, and I don't know why. It has a diurnal pattern in urine. It doesn't in serum. I'm still kind of trying to wrap my head around that. What we do with DHEA is we measure the sulfate, and then we measure the 2 biggest metabolites. So we add those 3 up, and we give total DHEA production. I like that number. I don't like looking at my DHEAS and assuming that's what's in serum, because they don't seem to dance together exactly. But here's my bigger point. If you're on oral DHEA and you do a urine test, what did we talk about? First pass metabolism, right? Now here's what I know. When I get DHEA levels up, the testosterone, I know this is vaginal, but look, the testosterone hangs for 24 hours. So then, if I give oral DHEA, it should do the same sort of thing. So what I do is I say, skip it for a day. I still have good solid numbers, but I avoid all that first pass metabolism. Now, I can't prove that that's entirely accurate. But what I do know is when people take oral DHEA and they take it the day of a urine test, you get big stupid numbers for testosterone and DHT and all of those metabolites, and I don't think they mean anything, right? That's all gut metabolism of your DHEA. So for urine, skip it for a day and you get pretty decent numbers, I think. So this is my summary. This continues to evolve, but there's been a lot of work that has gone into this. So the let's just say the evolution has really slowed. Now we're into microevolution, so that's good. But you can use that as a resource so that when you leave and you forget, why can't I use serum with oral progesterone? It'll tell you, remember, the kinetics are too fast, right? And this will give you an idea of where you can go with confidence. We'll talk a little bit, this is a little slanted towards the females, but after Mark's excellent lecture on testosterone and male health, we'll circle back around and do a shorter lecture and just kind of go through some of the male options on that. So that's it for hormone replacement monitoring. Thank you for your attention.